Welcome back to the Pro PA podcast. I'm your host, Prof. G, and in this episode of the MSK101 Clinical Medicine Brief, we're diving into one of the most common soft tissue masses of the hand and wrist, the ganglion cyst. This high-yield topic is simple, but it's often tested and frequently encountered in clinical practice. Let's break it down and make it stick. Let's dive in. Did you know that ganglion cysts are sometimes called Bible cysts? Because in the past, people would slam a heavy book, often a Bible, on the cyst to rupture it? Do not try this at home. Let's dig a little deeper. So, what is the kinderpatho of a ganglion cyst? Well, basically, these are non-cancerous, mucin-filled synovial cysts that commonly develop along tendons or joints, most often in the wrist and the hand. They are caused by mucoid degeneration of connective tissue, leading to outpouching of synovial fluid from the joint capsule or tendon sheath. So, how do these typically present? Well, most commonly, we see them in the dorsum of the wrist at the scapholunate joint. They may also appear on the volar wrist, on the foot, or the ankle. These appear as smooth, round, firm, and fluctuant masses. They're usually painless, but can cause aching and pressure or weakness, especially if they're encroaching on a nerve. They're often mobile and they transilluminate, and they can fluctuate in size or disappear spontaneously. All right, so how do we diagnose these types of cysts? Well, it is a clinical diagnosis based on location, appearance, and transillumination. Ultrasound can help confirm a fluid-filled structure, and an MRI may be used if diagnosis is unclear or to rule out other pathology. As far as treatment, reassurance and observation are going to be used for asymptomatic cases. We can also do aspiration, which can be done in a clinic. However, might see up to a 50% of cases are going to recur. And we want to use caution in those volar cysts because of the adjacency to that radial artery. Surgical excision can also be done for recurrent, painful, or function limiting cysts. We have lower recurrence rates compared to aspiration. One other option is an aspiration with injection of localized steroids, and this might also reduce the recurrence rate. All right, now let's look at the book med versus the street med. So, book med, observe, aspirate, or surgically remove depending on the symptoms. Street med, well, patients hate the watch and wait method. I've seen it time and time again. Many show up worried about having some sort of tumor, and so you need to take the time to educate them and discuss their options. And please, no slamming of Bibles. All right, let's wrap this up with some clinical pearls. So, always try to transilluminate to differentiate a cyst from a solid mass. If you have a cyst that you drain, remember recurrence is common even after aspiration. If it's painful or it limits range of motion, you might want to consider excision. And don't forget to assess for radial pulse and capillary refill before and after any volar wrist intervention. All right, it's time to test our knowledge. So, we have a 30-year-old woman who presents with a painless, fluctuant mass on the dorsal aspect of her wrist. It transilluminates. What is the most appropriate initial management? Is it A, immediate surgical excision, B, antibiotics and warm compresses, C, observation and reassurance, or D, corticosteroid injection? I'll give you a few seconds. If you chose C, you are correct. The correct answer is to observe and reassure. So, if the patient has an asymptomatic ganglion cyst, no intervention is needed, at least initially. Question 2. Which of the following is a risk associated with aspiration of a volar ganglion cyst? Is it A, ulnar nerve damage, B, carpal tunnel syndrome, C, radial artery injury, or D, septic arthritis? I'll give you a few seconds to think about it. If you said C, radial artery injury, you are correct. So the radial artery lies close to volar wrist cyst and must be avoided. All right, so some final thoughts. Ganglion cysts are benign, common, and usually nothing to worry about. That being said, location matters, so be cautious with those on the volar wrist and educate patients about recurrence. Most importantly, avoid outdated home remedies. Love what you're hearing? Hit follow on the ProPA podcast or check out more clinical cases, reviews, and physical exam tips on our YouTube channel, Professor G PAC. And don't forget to share this episode with a classmate or a coworker. As always, this is the ProPA podcast, where future pros in medicine are made. I'll catch you in the next episode.